during senior residency also I feel that I can do each and every intubation in my residency also. But when I transitioned to critical care medicine and went to the learning for critical care medicine, it was a cultural shock for me that how they do intubation. There were no any specific training or schematic training to us in medicine resident that how to do intubation. So I was taught intubation like my R2 was doing intubation. He gave me scope, he gave me one tube, and he told me that when your patient got expired, you just do the intubation, try to learn to see the vocal cords, and when the next opportunity comes, you try to do intubation in that live patient. So when I do a first intubation of my life, that I know that it was a hepatic encephalopathy patient, I do not have to do anything. I just introduce the scope, and patient was too much encephalopathy, and just I was easily visible to vocal cord and do the pass the tube, and I was very happy that day. I even gave party. So during medicine residency, we were taught that if you know the intubation, now you are senior, so you can manage the emergency on your own. But when I transitioned to the critical care medicine residency, then there are some concepts that came from the anesthesia part, and then I tried to again go through the books and try to read that part, how to do error management, and then I learned deeply and try to finish or try to improvise my skills. So this was just an overview, not a detailed topic. Just
generally medicine department માં રેસિડન્ટ જ્યારે ઇન્ટ્યુબેશન કરે ને ત્યારે કાં તો મોડ ઓફ ડેથ માં હોય કાં પોસ્ટમોર્ટમ હોય.
Yes.
બરોબર, એન્ટીમોર્ટમ જનરલી હોતું નથી.
Unless we do 50 to 100 procedures, the my procedure is just આવી રીતે કરવાનું છે એટલો જ ખ્યાલ હોય. The short neck, broad neck, so many so unless
એક કેસ તમારા માટે નવો સિરમ માટે
unless 50 to 100 procedures are done,
everything is new. In every case is set. So basically, and that is also different for anesthesia people also, because they are doing intubation on and off in operating room, and there is also difficult scenarios that are happening in ICU. So anesthesia is always a planned procedure. They look for the facilitation of the surgery, so you have plenty of time to investigate and assessment. But indication in ICU are, we all know that there are many comorbidities. If neurological, that patient is not able to patent airway, basically baseline respiratory pathologies, baseline cardiovascular pathologies, high metabolic demands like septic shock. These all the alters the normal physiology of a patient, and it becomes challenging in ICU to do intubation. So what are the difficulties we feel, people feel outside the operation theatre? So first is the environment. So our ICU environment is very much crowded. There are too many machines and gadgets. There are very limited space at the head end. There are lighting are often suboptimal than the operating room. Equipments, all the airway equipment that we use in our operation theatre are not available to the ICU settings. Access to the advanced equipment is also limited. So you have a video laryngoscope, but it is allowed to you only when your assistant professor is available or a HOD is available. You have a fiber optic bronchoscope, but you can only use when there is a HOD is available. So there are not all the advanced equipment is available in ICU in the odd hours. Monitoring. Monitors in the ICU, there are always one monitor which is on the head end, which is not usually the procedural person will not able to see constantly that monitor. So there is a one person who can monitor and vitals and inform any emergency happens to them. So yes. So in ICU, in operation theatre, there is always a two monitor. One is towards the surgeon that he does the procedure, and one is facing towards the anesthetist. That is a bigger monitor than this. So they can always keep a check on vitals. Capnography is not always or not standard of practice in our ICU. Oxygen supply, all the ICUs are having only one, mostly ICUs are having one single line of oxygen. So when you do pre-oxygenation or some other procedure, there is a bubble humidifier is attached, and when you intubate this patient, you have to remove that bubble humidifier and attach the ventilator ports. And oxygen ports usually available in operation theaters. Training, limited cases for training. Infrequent exposure to advanced and rescue techniques in outside the team, multi-professional members. So every time there are new sets of team members that comes to do a intubation. Inconsistent team leader. So I am doing duty. So I am today team leader. After 2 to 8, some other one is team leader. And in these 2 to 8, there are some 4 or 5 other staffs are part of the team members. So it is always an inconsistent team member. Equipment may be unfamiliar to all the team members. Airway assessment is limited time. There are also some devices like cervical collar is applied to this patient, or a patient is very much unconscious or agitated, and it is very uncooperative patient, our ICU patients are. So these all are the equipment and environment related difficulties. Then there are patient related factors. So there is aspiration. These patients are not always fasted. Otherwise, in operation theatre, we have kept NBM all the patients overnight. Oxygenation with CPAP or a non-invasive ventilator will increase the risk of gastric distension. Difficult airway we usually encounter in ICU, like facomaxillary trauma, neck trauma, if any prior intubation done or prior tracheostomy is done. And most important difference between operation theatre and ICU is, in ICU intubation is always an acute emergency, and it always present at the urgency. So is there any procedure we do in an urgency or emergency? We are going through first challenges. And there is a rapid deterioration of patient due to decreased physiological reserve, respiratory physiology or high metabolic demands. Pre-oxygenation is not as much adequate in a normal patient that we encounter in OT. Our patient is already having a community acquired pneumonia or a severe ARDS or suffering from COVID pneumonia. They will not have a adequate pre-oxygenation. Cooperation due to agitated coma patient. Unstable respiratory physiology, unstable cardiovascular physiology. No awake intubation due to hypoxia or agitation. And another most important difference is there is no wake-up call if intubation fails in ICU. In OT, if you fail to do a intubation, you can wait till all the effect of drugs wean off, and you can make the patient awake. There is no option of making awake the patient in ICU. You have to secure airway. Staff related factors, resources. Staff always many staff lacks airway experiences. Senior staff not always present. May lack out of our airway care coverage if anything happens in out of 9 to 2 or 3 a.m. There is not always the same proficiency available. Equipment are not universal. If I am doing intubation, I prefer some equipment. Another one is doing intubation, he prefers some other equipment. And the staffs are not familiar with that person's equipment or drug choice. Training, focused training of airway in ICU is not frequent. Now they are doing too many workshops for that. But before that, there is no any focused training for ICU. Crisis management training is very important in ICU. Sometimes it happens very rare, but sometimes our staff fail to identify that this patient requires intubation or this patient is having an airway emergency. And another important factor is, if we fail to intubate this patient or fail to secure airway, there is a lack of immediate surgical airway team. So if in night 2 or 3 a.m. I fail to intubate this patient, there might be some possibility that I will not get a support for a emergency tracheostomy from a surgical area. So everyone, I also felt before doing all these things that I am very good intubator and I can do intubation with each and every patient, and that then everyone else also feels that they can intubate. So what these people have done? So these people have published a study in 2021. It was a pure observational study. It was included 197 centers of 29 countries, and they have done only observational studies how the intubation practices are happening in these all centers. They have only included maximum 20 patients from the one center. So there is no any selection bias like some centers are doing excellent protocol follow, so there will not be any bias. So patients were intubated by residents with 2 years of experience is 51.9%, anesthesiologists is 54%, Inclusion criteria is any patient more than 80 years of age require intubation outside the operation theatre. So primary outcome they want to see that occurrence of at least any one of these following event within 30 minutes of starting the intubation procedure. So what are these three events are? One is severe hypoxia, so saturation falls to less than 80%. Second is cardiac arrest. You try to intubate the patient and patient went into cardiac arrest, then you have to start CPR straight away. Or three is cardiovascular instability. So systolic PP fall less than 65 for at least once, or a systolic PP falls 90 millimeter of mercury for more than 30 minutes, or any new requirement of vasopressors or fluid to maintain the adequate blood pressure. And if your patient is having already saturation below less than 80%, it was not included in the study. So what were the observation? So major adverse events, that primary outcome, 45% of the patient had a major adverse event. Out of this 45, most of the patient had a cardiovascular instability, and this most of the cardiovascular instability that falls into the new need of or increase the vasopressor. Severe hypoxia happened in 9.3 patient and 3.1% patient has a cardiac arrest. So it is not a very uncommon that there is a major adverse events happening during intubation. So yeah. So these are secondary.
Pre-intubation.
Yeah, no, during intubation. Intubation.
Within 30
Occurrence of at least
start.
one of the following within 30 minutes of the starting the procedure. So at least 45% patient had developed any major event. So these three are major events, and these are some another small secondary observation they have done. So esophageal intubation is also not very uncommon. New onset cardiac arrhythmia is also very not uncommon. Yes, aspiration pneumonia is also very not uncommon, 4% of the patient, and dental injuries, that is very common in normal practice, but that was also not uncommon in this patient. Even airway injury, 21 patient had airway injury in form of surgical emphysema, tracheal injury, that is also tricky. What were their observations? So out of all, they have included 3,000 patients. Out of that, only 51% patient was had a standard protocol. In institute protocol that we are having this institute protocol. Whenever we are intubating this patient outside the OT, we will follow this protocol. So only 51% population will undergo into standard protocol, and 34% of the area will not have any standard protocol. They do and they know it. તમને જે ઠીક લાગે તમે કરો એવી રીતે બધી જગ્યા. Pre-oxygenation method, bag and valve mask is 62% and non-invasive ventilation is 11%. This is going to increase. More and more people are going to use non-invasive ventilator method as a pre-oxygenation method. Induction agent is propofol, most commonly used 36%. Muscle relaxant is used in 75%. And out of 75, the ropinirole and scopolamine are the most common used neuromuscular blocker in intubation. So direct laryngoscopy was in 81%, and they out of 3,000 patients, most of the anesthesiologists prefer intubating or passing tube without any airway adjuncts. Like they they introduce the tube without any stilate or boogie. So only 1,055 patients required any stilate or boogie to pass the tube. So out of that, stilate was most common. First, confirmed intubation. Though everyone feels that wave capnography is the gold standard to confirm the placement of tube, but still 5-point auscultation was used in 56% of the patient. And first pass successfully is around 2036, this type of patient. So our many Gujarat hospital were also part of this study. This is published in JAMA.
First class and how many percentage?
Around 2, 3, 6, 9, 7, 80 plus percentage first class. 80 plus.
So you can successfully pass tube in 80%
Yes.
of patients.
Yes.
With
So,
few
first part-
adverse events.
Yes. So So how
There are
to,
even that adverse event amounts to 50%.
yes, yes,
Or maybe 10%.
can be temporary. So what are the adverse events are happening and what we can do to prevent that adverse event? That is the main treatment protocol or main intubation protocols. So first pass is known as once we introduce the laryngoscope, even if we do not try to pass the endotracheal tube, that is called as a first pass. But if we introduce the laryngoscope inside the mouth, that is called as first pass. So this also happened in Spain. They done study on the same subset of patient. So once a patient was intubated by anesthesia resident or anesthesiologist in OT, in the same subset of patient.
Going because recently there was a problem of cardiac arrest during the and that person was subjected to brain. So if atrial cardiac arrest occurs, suppose
Yes.
with first part, how long does it occur and in how many percent of the patient it lasts long?
So yes. Because cardiac arrest in 93 patient with return of spontaneous circulation that happens in 49. So half of the patient had a return of spontaneous circulation. And half of the patient were died in intubation.
40, 50 died.
45. Yes.
Means if cardiac arrest occurs,
Yes. So half.
even right introducing laryngoscope first part,
Yes.
so 50% will
Patient.
survive.
Yes.
But only the incidence is 3%.
Yes.
Out of 3%, out of 100 patients, 3 patients.
Yes. Out
So
of
we
100
need to say that out of 100 intubation done, 1.5% will die.
Yes, possible. Even more than that.
Uh,
Even more than that, sir. In Indian scenario.
Because see, recently one of the obstetricians, underwent that claim. Maybe they might not have, supplementary, one is like a defibrillator in one instrument and ultimately he had to pay 15 to 20 lakhs.
That may be the operating room scenario.
Yeah.
And this is ICU scenario. That might be not forgivable in operating room scenario. You might be taking a planned procedure in operating room scenario. So
Are we routinely giving atropine during intubation in ICU?
we are
Or should it be given?
no, we are giving fentanyl to reduce the hyperreactivity of the opioid, and we keep rarely atropine and adrenaline clean.
So these are vasovagal,
Yes.
right?
No, sometimes
This is
these are due
function.
to pre-modi condition, baseline condition. The patient were already on 90% FiO2 with 100% oxygenation, or might someone have a cardiogenic shock, 90% 15 ml
Do you
already.
have the analysis, subset analysis of the deaf patient study method? We have to see because first it has to be vasovagal. Whatever, laryngoscope નાખ્યું ને arrest થાય છે, that has to be vasovagal.
This is not actually patient come in ICU now. The condition of patient is so sick, is severely hypoxic. 3-4 INO drops are going here and there. And when
That is different story. એ તો પછી ICU માં બીજા ત્રીજા દિવસે ક્યારેક intubate
yes,
કરવું.
definitely.
So first which is happening એટલે આનું subset analysis મળે તો ગોઠવેલું નથી.
And some people are due glycopyrrolate.
Glycopyrrolate, yeah, that is the equivalent to atropine only. No?
Yes, to prevent
Yeah, so that was the
and then
question.
secretions of after intubation is also reduced.
So that we are not giving routinely.
We are not giving
We are
ICU.
not giving. So to whom you give? And that is over pre-intubation or post-intubation?
Intubation में किस पाने routine की आपको जो
कौन है आप लोग?
If it is a when it is a crash intubation, we have no time to
એટલે એમાં તો નહીં પણ પ્લાન થોડો પણ ટાઈમ
neuro patient with secretions so we have a 5-10 minutes time then we give MSET and glycopyrrolate to prevent aspiration and vasovagal.
You take,
But it is not a standard guideline that બધાને આપવું એવું
No,
નથી.
there is no standard. In OT there is always they give pre-medication.
Pre-medication. Because OT is
એટલે ઓટીમાં તો કમ્પલસરી
compulsory.
તમે
Patient આવે ને 3 to 5 minutes પહેલા intubation પહેલા they give glycopyrrolate, MSET અને if reactive error તો they will use short steroid dose also.
તમે સ્ટડી કરી શકો બધાને ગ્લાયકોપાયરોલેટ આપવાથી આ ઘટે છે કે નહીં કાર્ડિયાક અરેસ્ટ.
glycopyrrolate, आपको तेरी mechanism, not mechanism of action, onset of action कितना समझना है?
3 minutes, 3 to 5 minutes.
3 to 5 minutes.
हाँ, atropine જેટલું fast નહીં થાય.
they have done the same. They have taken the same patient. So if a patient require intubation in anesthesia and within 1 month, and they require intubation in ICU for whatsoever reason, they have intubated the same patient, and they have seen for the any difficulty observed during ICU intubation or not. So they have concluded ICU intubation is associated with more complication in the same subset of patient, which was not observed during the operating room procedures. So here also, when patient was intubated in OR, the procedure complications like hypertension, hypoxia, esophageal intubation is there less. But the same subset of patients were intubated in ICU due to some other reason. Procedure complications were significantly increased during ICU intubation. Same subset of patients. So this is Samir Jabbar paper. He did a wonderful study in the 3 ICU. They used the 3 ICU period when they observed a 6-month observation period where there was no any standard protocol during the 6 month of period. And after observing all the events, after they introduced the 10-point protocol, and after introducing 10-point protocol, they have again observed for the 6 months. Then what are the differences made? So they have found that there is a significant decrease in intubation-related adverse event in the intervention groups. So once they applied this 10-point protocol in their ICUs, there was significant decrease in the peri-intubation adverse event during their critically intubating. Then this is a guideline for
What about 10 point?
house. So now that this was published in 2010, now this 10 points is included in all the standard protocols. So this is checklist. So we have to do 1, 2, 3, 4, 5. This is checklist. This is standard protocol in all the hospital, all the ICU. They have included in international guidelines. So this was the first they have done in 2010. So these are some terms that is for facilitation, like drug-assisted intubation. Any intubation that required in use of medication, that is for drug-assisted intubation. Rapid sequence intubation is you will hear more and more. In rapid sequence intubation, where the patient is not NBM, we try to introduce sedation as well as neuromuscular blocking agents simultaneously, and we will not apply any positive pressure ventilation during that period, and we will directly intubate this patient. So this rapid sequence intubation is very new thing. And another thing is delayed sequence intubation. In delayed sequence intubation, we first give sedation, try to calm down the patient, and after calming down the patient and giving the pre-oxygenation, we will do neuromuscular block. So this is modified rapid sequence intubation. Any modification into classic rapid sequence intubation is known as modified intubation. So these are the rapid sequence intubation. These are main 7 P's. 7 P's are the part of rapid sequence intubation. These 7 P's are also incorporate that techniques. So there is a 0 time, like when you have to give a induction and paralysis. So before 0 time to before 10 minutes, you have to start preparation and plan. After preparation and planning, you have to do a pre-oxygenation, pre-treatment, then paralysis and induction, then positioning, then after positioning, placement with proof, and then placement with proof, then there is a post-intubation management. So there are all these 7 steps that incorporate to safe endotracheal intubation practice in ICU.
So what are these related with oral intubation?
Yes, only I am talking only about endotracheal oral intubation. Nasal intubation is usually done in operation theatre. It is a
Sometimes in
ICU also done, but
because if the say cervical spine trauma is needed,
yes.
or as you rightly said, our maxillofacial injuries are there.
Yes. So steps will be remain the same. Only the this placement with proof, that will be different in nasal intubation. You have to.
But suppose if you are unsuccessful by say oral intubation,
Yes.
do you go for nasal intubation, or do you use oral
So
laryngeal
yes.
airways?
So there are steps for that. So if we do not succeed to do endotracheal intubation, then there are 2 to 3 respiratory adjuncts we can try. And if there 2 to 3 respiratory adjuncts also fail, then we have to directly go for the front of the neck approach. So plan and preparation. Plan and preparation is the most important step for doing any intubation. you have to plan in a way that after once you start the planning, your any of the staff don't have to go outside your cubicle to take anything. You have to plan in a way that everything is available nearby you, and all of your staffs are accountant or competent with all the proficiency. So you have to planning and preparation is the most important step. Assess to need to secure the airway. Assessment for the difficult airway. So this is for usually for the trauma and for this patient, but you have to understand any airway in ICU is a difficult. You have to mean that it is a difficult airway, and you have to prepare in a form that this patient will have a difficult airway. So these are some mnemonic like lemon external. So any facial trauma or beard or a large tongue, that will be shown that this is a difficult airway. 3/3/2 rule. This is very difficult to see in a acute management or any emergency. Malampati score is also not we are fond of seeing in a emergency procedure. Obstruction, if you have any stridor or gurgling sound or any audible obstruction, then it can increase the.
There are 3 F in mouth.
Yeah, so 3-finger mouth. So if your patient does not have a 3-finger mouth, you will going to encounter a difficult airway. Then there is a difference between mentum and have. So the less than 3 distance between hyoid bone and mentum, you are going to encounter a difficult airway. And 2 finger between hyoid and laryngeal components. So you are going to have a difficult airway. But this is for a book purpose. This is not we are going to do in a emergency situation. So we have to see that short neck, obstruction, obstructive sleep apnea, cervical trauma, limited neck mobilities, beards. These are all the we can see that this is we are going to have a difficult intubation rather than doing what is.
So this chronic tubercular, there are a lot of patients are in submucous fibrosis.
Yes, submucous fibrosis last one. These all are difficult intubation. And only score that is validated in a critically ill patient is this MACOCA score. MACOCA score does not only encounter the anatomical difficulties, they also encounter physiological difficulties. Like if patient you are having a obstructive sleep apnea syndrome or a reduced mobility or cervical spine, or he is having a coma or a severe hypoxia, that will be an increase in the score. Only validated score for critical ill and history of out of this, if patient is having a history of difficult intubation, that is the most important factor that this patient is going to have a difficult intubation. So when we usually do ICU, when a patient posted for a operative case, and if they encounter a difficult intubation during the OR case, and it is a straight away case, and we have to extubate in a 24 or 48 hours, they give over to us that this is a difficult intubation case. So when you are extubating this patient, keep everything ready. So if anything happens to this patient, there will be a catastrophe while repeat intubation of this patient. So difficulty or history of difficulty intubation is most important factor in ICU. Team preparation, at least 3 person, ideally presence of 2 operators, appropriate roles and team briefing. So what person going to do what. Patient preparation is at least take a 2 large bore IV access, ask for any drug allergies, ask for any contraindication to any drug, NBM status. NBM status is not going to happen, but most of our ICU patients are having a rice tube in situ, so we try to do a suction from rice tube before intubating all patients, if rice tube is in situ.
You find any allergic problem to these muscle relations?
Sometimes yes, sometimes that can happen. So if there is a family history or if there is previous history of any allergic reaction to muscle disorder, muscle purpose.
And this, the antibody, possibly penicillin group of antibodies, sometimes prophylactically before the operation, that is, even in the ICU, that is.
So, in all the surgical procedure, they have to give a pre-surgical prophylaxis before 1 hour. So they are preferable is cephaloxime in all the patients. So sometimes patient might have a cephaloxime allergy, and they give or monitor that this patient develop reaction or not.
And atracurumine specific histamine release.
Atracurumine specific histamine release.
Atracurium use करो ना muscle relaxant. Particular subset patient has a histamine release, the spasm and hypotension.
Succinylcholine will have a severe devastating effect. Dropilonium can have an allergic reaction. So what are the equipments we have to see? So there should be a self-inflating ventilator bag with reservoir bag and ventilator set. Face mask of different sizes. Oropharyngeal airway, nasopharyngeal airway, working suction line, working oxygen line. That is most important. Everything is ready, but we have to see one of the team member that everything is working. Sometimes patient comes with the venous cannula from outside, and we see that the vein is inside, but we have to see that this vein is patent or not before starting any procedure. So two working laryngoscope at least with different sizes of PV tube, lignocaine jelly, 10 ml syringe to inflate the tube cuff, stethoscope to check for the tube, stellate, gum elastic to be Magill's for cell, ready and cut tube fixators. It is sure to ideally, but we are not an ideal situation. Drugs, there are many drugs that we can use during the intubation, and rescue devices like LMA, video laryngoscope, fiber optic bronchoscope, or picothyroidoscopy. So we can keep a LMA, video laryngoscope, and fiber optic scope. Bronchoscope is out of our ICUs, and it is very costly, so no one is keeping, but we can keep a LMA. Drugs that we can use for during facilitation of intubation is keep ready vasopressor for hypotension. So we have seen that 50% patient is having a 45% of patient is having a cardiovascular instability. So during intubation 70 BP, and we will ask sister start NORAD, then she will go to prepare NORAD and attach a line, and it will take more than 4 to 5 minutes. So we have to keep ready of NORAD line infusion form in a flush manner, and to start immediately if possible. We can prepare for the short-term sedation, and prepare for the long-term sedation. Fentanyl as a symptomatic drug, 2 to 10 microgram per kg, onset within 67. Drawbacks are hypotension, vomiting, and severe muscular rigidity in very high dose. This is truncal rigidity. Induction agent, most common, most preferable or most advisable to use is a ketamine, 1 to 2 milligram per kg. But ketamine is not easily available in all the hospital. It comes under restricted drug. You have to sign at least 3 forms to available ketamine to use. So we have also seen in that study that they are also using most commonly is propofol, because propofol is commonly available. Intermediate is 0.2 to 0.6 milligram per kg. There is a risk of severe adrenal suppression if with intermediate sepsis. Or we can simply use midazolam in a high dose, 0.1 to 0.2 milligram per kg, combined with the fentanyl. And after fentanyl, we can use a neuromuscular blocker. Only these two.
Do we use thiopentone in ICU?
Thiopentone is 5 to 7 milligram per kg. We were using 5 to 7 thiopentone during the initial days of intubation in critical care patient. It is still prevalent, but there are very high chances of hypotension or myocardial depression was happening with that. So we are having safer and safer drugs available to use. And phenobarbital is, I am a medicine person. I will have a difficulty in judging the response of phenobarbital in some patient. So it is not a single drug. Use a drug which you are familiar. Use a drug which some effect that drug will cause, and you are familiar with it, that effect.
Ketamine and propofol with the medicine ma to use not to.
So propofol was available.
So that excuse was not good, but yeah, they are still using thiopentone in ICU.
But intermediate and fentanyl has a
very fantastic.
Safest.
yes,
very
stable
fantastic
hemodynamics.
अरे 10-12 वर्ष पहले जैसे समय वाइस में था तो यार thiopentone use करता क्या है?
It is very fantastic response with intermediate. I have used in some cells.
Pressure according.
So neuromuscular blockers, if you are using a neuromuscular blocker, there is only these two choice you are have nowadays going to available to you, succinylcholine and dropilonium. Succinylcholine will have 1 to 2 milligram per kg. It is rapid onset, and it is very short duration. So it is a safer for if you want to anticipate that this patient might have a difficult airway, and you want to wear off his effect very fast, then you can use succinylcholine. Onset of action is within 60 seconds, and drug of choice for emergency when not contraindicated. So there are many contraindications for succinylcholine. So dose is, I have remembered that 1 to 2 milligram kg for succinylcholine and then do half of that 1 to 2 milligram and in roculoline. So I have remembered that a very simple manner. Roculoline is also a very rapid onset. Intubated condition is achieved within 1 to 2 minutes and it lasts up to 10 to 20 minutes. It is relatively safe if there is no allergies. So pre-oxidation, there are three methods are usually now recommended to do
કેટલું છે
yellow.
કેટલું બાકી છે
The on the 5 slide, 5 slides.
એટલે બધાને સમજવું પડે તમે રસ્તો કરશો તો મજા નહીં આવે એટલે એકાદ એક સ્લાઇડ ડિટેલમાં લઈ લો બાકી સ્લાઇડ નેક્સ્ટ ટાઈમ
ठीक है.
Next time.
નેક્સ્ટ ટાઈમ આવજો હા પાછો બીજા ના
Puneet,
No,
next
no,
time.
right.
Amit.
એટલે 4-5 સ્લાઇડ બાકી એટલી પૂરી કરાવજો
Yes.
5 slide.
હા બસ ને એક કર લે સાહેબે કીધું ને
So pre-oxidation is the very new thing I learned when I transferred to critical care medicine. There was no such a thing of pre-oxidation was taught to me during my residency. So pre-oxidation was achieved with 3 type of maneuver. So in the absence of respiratory failure, tight fitting mask with 50 liter per minute oxygen for at least 3 minutes. So it will do all the denitrogenation of our lung airway and it will have a good safe apnea time during the procedure or we are doing the direct laryngoscopy. So our critical saturation like less than 92%, 90% saturation will not go immediately during the procedure.
It means in the absence of suppose if the patient is not on oxygen
Yes, yes,
before something happen
yes.
તો પણ
So
આવી
yeah,
શકે.
just because our room air is containing only 20% or 21% of oxygen, so we have to give a pre-oxidation at least for 3 minutes or a 6 to 8 vital capacities, forceful vital capacities. So that will all remove all the nitrogen from the oxygen and we will have a safe apnea time. If your patient is not having any
5 મિનિટ સુધી વાંધો નથી આવતો.
if you not having any lung pathology, so after giving succinylcholine, 90% saturation will maintain up to 6 to 7 minutes. But it is not always possible in ICU. So respiratory failure, you try to do pre-oxidation with CPAP or NIV with speed of 5 and pressure support of 5 to 7 with a tidal volume targeting of 7 to 10 ml per kg. And with HFNC, HFNC is very costly device we are not using for intubation. So HFNC with flow of 30 to 60 liter per minute, we can do pre-oxidation.
ગુડ ઇન્ટેલિજન્ટ
And this